Hi, I'm Chris Fanta. I'm a member of the Pulmonary and Critical Care Medicine Division at Brigham and Women's Hospital, professor of medicine at Harvard Medical School, and director of Partners Asthma Center. And I wanted to talk with you about chronic cough. Not necessarily because I don't know how many questions there will be on a board exam regarding chronic cough, but in terms of your practices, it is, I think, probably, if not every day, pretty close to it, a very common complaint that you're asked to deal with. And I thought it would be fun to introduce this new topic to our review of pulmonary medicine and approach to the patient with chronic cough. And I have no conflicts of interest to disclose. So if there were a subtitle for my lecture, it would be this: the bottom line, I believe there's more to chronic cough than asthma, postnasal drip, esophageal reflux, maybe ACE inhibitor induced cough. I'd like to encourage you to think more broadly. If you get trapped in this narrow view of the world of chronic cough, I think we'll miss many patients. So where did this idea come from? Over the years, we were taught, as quoted here, that postnasal drip syndrome, we often refer to it as upper airway cough syndrome now, asthma, and/or gastroesophageal reflux disease are likely to be the causes of chronic cough almost all the time in a non-smoker not taking an ACE inhibitor with a normal or essentially normal chest x-ray. I don't think life is that simple. And furthermore, we were taught that the cause of chronic cough can be determined almost all the time, and that once you figure out what's causing it, you can get a specific treatment begun with a success rate of 85 to 98%. And that was the dogma that we heard for many years. And if you treat chronic cough as I do, you have this sense, I must be an idiot. I don't have these dramatic success rates. What am I doing wrong? And I think what we're doing wrong is assuming that all cough is as simple as asthma, postnasal drip, and reflux. So let's just take a minute together and review the mechanism of cough, just as it's such a beautiful physiologic process. We'll talk about pathologic cough, that's our focus, in particular chronic cough, and then in the end, antitussive therapies treating the symptom of cough. So the mechanism of cough begins with these cough nerve endings, the vagal afferent nerve endings that can be have various names. It's transient, receptor, potential, vanilloid. One that's not important, the purinergic receptor 2x3. We'll come back to that. But these sensory nerve endings richly innervating posterior pharynx, the larynx, the central airways. You know about that nerve, the Arnold's nerve, the branch of the vagus that innervates the auditory canal and can occasionally be stimulated, cough with the Q-tip in the ear canal. So these vagal afferents then sending signals centrally to the cough center in the medulla, and then from that cough center, and you can, to some extent have cortical input controlling or at least suppressing cough or giving a cough voluntarily. But from that brainstem comes these carefully coordinated sequence that involves first inspiratory muscles, typically a breath in, expiratory muscles, closing the larynx briefly, opening, some narrowing of the airway smooth muscle to increase expiratory flow. Here's a cartoon indicating the presence of these vagal nerve receptor endings in the pharynx and larynx and central airways. One wondered about pericardium and stomach, and here's that Arnold's nerve in the ear canal. And out comes exhalation, a big forceful blast. The glottis is closed, pressure builds up, the glottis opens, it releases. There's this noise, and then can be continued cough. And I just wanted to show on a flow volume curve. I find it so interesting. I don't know if you're comfortable looking at flow volume curves with exhalation here. Above the horizontal line, here's inhalation. But during exhalation, big breath in as hard as you can. This is the envelope. No matter how hard you try, you can't get flow to exceed this expiratory envelope except with a cough. Here are these spikes, increased flow, trying to move the mucus out of the airways centrally to the mouth and to be expectorated. So high flow rates achieved through the airways with an effective cough. And we've come to think of cough in terms of its duration. This is mostly helpful in retrospect, I suppose. But those with an acute cough, less than 3 weeks, I think we're thinking commonly respiratory infections or toxic smoke exposure or something like that. 3 to 8 weeks, that subacute cough might be the perfect description of pertussis or whooping cough that can linger several weeks and then resolve. But what about the patient whose cough just goes on and on and on and has come to see you now for relief? Here's an example of a patient I saw, an anesthesiologist at our hospital complaining of this incessive coughing that was interrupting her work. They wouldn't let her into the OR with this cough. It had been going on, this was pre-COVID-19, I might point out. She had been coughing nonstop for more than 2 months, more than 8 weeks. Her cough sounds like a walrus, a sort of bark-like cough, makes her have to leave the operating room. Never smoked cigarettes. Cough is non-productive, no fever, no chills, night sweats, weight loss, other clues for other things that were going on. No shortness of breath, other than during these paroxysms of coughing. Her past history, well, she had some seasonal allergies and eczema as a child, but they went away around menarche. And she denies symptoms of reflux other than after spicy meals. She has rhinitis only when she goes for a run in cold weather. Nothing strongly pointing to asthma, reflux, or postnasal drip in this history. So we're going to ask more questions. She said no sputum. Do you ever cough up phlegm? I think causes of airway inflammation and mucus production may be a useful clue, and we'll want to analyze the sputum. How did it start? Was there something at home, some event, in her case, of respiratory tract infection? Have you had prolonged cough before? What makes it better, worse? Is it the cats, the season? Are there clues to allergic triggers? Any new exposures in your work environment, in your home environment? I think those are questions we should be asking about potential inciting events for this chronic cough. I don't think that description of my cough sounds like a walrus is particularly helpful. Maybe you're good. Maybe you can distinguish tracheomalacia cough from other coughs, but in general, I think it reflects cavity size and not any particular etiology of the cough. Patient who says a cough comes on when I lie down at night, that doesn't mean it's reflux or postnasal drip. Often coughs get worse with positional change, and it's not diagnostic. And the cough that comes on every afternoon at 3 p.m., I've heard that, you've heard that. I don't think that's specific. And I do want to point out that chronic cough can be, incredibly debilitating, I guess. I mean, because of its associated symptom. Can trigger incontinence, cough-induced emesis or dry heaves, cough-induced syncope. That's not convenient. Trauma to the ribs from vigorous coughing, and then just the social embarrassment. I can't go to the theater anymore, doctor. I can't go to the parties, or in the age of COVID-19, I can't go around any other people because they think I'm infected when I'm coughing all the time. Her physical exam is normal, and we want to do a thorough exam, not just chest exam, listening for wheezes and crackles and adventitial sounds, not just clubbing as a sign of respiratory disease. But let's look for sinus disease and nasal disease. Let's look for heart failure and the jugular veins and peripheral edema. Let's look at joints for a systemic inflammatory disease and skin rashes, etc., in case her cough is part of a systemic disease. And and before we get trapped into this narrow thinking of it must be asthma, postnasal drip, or reflex, let's admit that it could be many different things causing her cough, from inflammatory diseases, infections, cancer, heart failure, some aspirated material, etc. Cough has many different etiologies. Besides the history and physical exam, I'm going to do spirometry. It's a great way to look for asthma. And do you know this test, exhaled nitric oxide? A real-time measurement in exhaled breath of the concentration of nitric oxide gas. It's available in specialist office such as mine. And an elevated nitric oxide reflects eosinophilic airway inflammation. So that's useful in thinking about asthma as an eosinophilic airway disease. Elevated exhaled nitric oxide is suggestive. Inhaled steroids suppressing eosinophilia reduces nitric oxide concentration. I do spirometry because it's easily accessible in my office, and it helps me to say, could this be asthma or not? For you, it may be a peak flow meter or referral to the BFT lab. And a chest x-ray, I think all of our patients with chronic cough should get a chest x-ray for sure. I mention oximetry at rest and with exertion just because I love doing it. It's free, it's easy, you get to see the patient in action as they move around. I don't know for cough as much as for dyspnea, but normal oxygenation at rest and with exertion rules out diseases associated with low diffusion capacity, like pulmonary vascular disease, emphysema, and interstitial lung diseases. So I find it very helpful. All right, let's go get that chest x-ray in our anesthesiologist. And it could have been, as this patient who presented with cough, a huge mediastinal mass of her Hodgkin's disease. It could have been this x-ray, not quite normal, and this patient had cough, very little dyspnea. Cough as the predominant feature. You can see it's just, I don't know, hazy, ground glass, CAT scan. Whoa, diffuse ground glass opacity. This patient had hypersensitivity pneumonitis after her visit to her summer home in Maine. And this patient, chest x-ray, actually was read initially as normal, but I think as we look at it a little carefully, maybe these hilar, I don't know, little plump. Anyway, I asked her to stop her angiotensin converting enzyme inhibitor. She did. Her cough didn't improve. We got a CAT scan. Can you make out the tiny little nodules, tree in bud distribution? In addition, yes, she has adenopathy here in the non-contrast imaging. Here's another lymph node, and she had sarcoid as the cause of her cough. It wasn't asthma, postnasal drip, or reflux. We thought more broadly. Our patient, the anesthesiologist, had a normal x-ray. So that brings us to what could it be if the x-ray is normal, but we started looking at x-ray. All right, what besides asthma, postnasal drip, reflux, and ACE inhibitor-induced cough? Let's admit chronic bronchitis, if it's a cigarette smoker, certainly would have cough, often with daily AM sputum. And bronchiectasis discussed in a separate lecture, often chronic or intermittent cough, often with purulent sputum. And I would like to introduce also the following that you may or may not be familiar with: eosinophilic bronchitis as a cause of chronic cough, rare but diagnosable. Post-bronchitic cough, which is exceedingly common in the in the season of flu, in the season of the fall with the children with their rhinovirus infections. Parents got a cough, cold symptoms went away, but the cough lingered, and there's no guarantee it'll go away within 8 weeks. I think maybe our anesthesiologist has post-bronchitic cough. And then, what if it's like that, but it's years? Cough hypersensitivity syndrome recognized as the cause of chronic persistent cough in a normal x-ray, and I want to highlight that as we go on. So let's just quickly run through these potential etiologies. Could it be asthma? Yes, it could be. We're going to decide based on pulmonary function tests. We'll define asthma as airflow obstruction that reverses to or toward normal in response to bronchodilator. If we need to, we'll do a methacholine challenge. A normal methacholine challenge is 95 to 100% accurate in excluding asthma. A positive methacholine challenge is suggestive with the right history, although depending on how much methacholine it takes to induce constriction, some patients with mild responsiveness to methacholine may have hay fever and sometimes a normal person. And we talked about exhaled nitric oxide in the diagnosis of asthma. This upper airway cough syndrome, there's a broad array of etiologies, and certainly the patient who describes recurrent sinus infections. I can feel the mucus draining down the back of my throat like a river. I'm constantly clearing my throat. I lie down on my back and I can feel it, and I'm constantly blowing my nose during the day. Yes, we'll treat their upper airway rhinitis and hope that the cough goes away. And the treatments are myriad depending on what you think the etiology is: antibiotics for infection, antihistamines, decongestion, nasal sprays, etc., nasal saline irrigation. If the history points to a diagnosis of postnasal drip, let's treat it and see if the cough goes away. So too with reflux. Patients said, oh my gosh, not heartburn, not my stomach aches, but true reflux. I have the feeling that liquid bubbles back up, dinner up into my throat a second time, behind the breast burning after I eat, and when I lie down at night, behind the sternum. Then I think we should treat the reflux and hope that the cough goes away. Maybe the mechanism is reflux of the pharynx with aspiration of gastric contents. Maybe there are vagal nerve endings in the esophagus that lead to esophageal bronchial reflexes causing cough. It is true that reflux happens in the absence of heartburn, the silent reflux, but I'll jump to this final point that in the absence of reflux symptoms, asking patients to treat their cough with proton pump inhibitor therapy that's been put to the test and proved to be ineffective. The patient, however, who's symptomatic with reflux, yes, let's treat their reflux. Elevate the head of the bed, encourage dietary changes. You know this, antacids and pro-motility agents, and we'll see if your cough gets better. ACE inhibitor-induced cough, I think, is quite common. 10 to 15% of patients treated with an ACE inhibitor are said to develop a cough. It can come on anytime. Certainly soon after, that's a points the finger at the drug that was started, but it can come on months after initiation of therapy. And I think if you have a patient with chronic cough on an ACE inhibitor, let's try stopping it. Maybe the cough will get better, even if they've been on it for a long time. We don't know exactly what the mechanism is, but it is true that angiotensin converting enzyme inactivates bradykinin and substance P. And so giving a medicine that inhibits that might, in some patients, lead to accumulation of these chemicals that stimulate the nerve endings and cause a chronic cough. And do an experiment, find an alternative. Now that's not difficult with the angiotensin receptor 2 blockers. Find an alternative, and the cough, if due to ACE inhibitor, should go away within a month. Give it a month off the drug. And I am clear in my mind in review of the literature that the ARBs don't cause cough. Now, could it be chronic bronchitis? If it's a cigarette smoker, for sure, although often the cigarette smokers don't complain of their cough, maybe because they cough and raise phlegm, and that's somewhat satisfying. Maybe they have don't want to be accused of having a terrible habit. But a patient who's a smoker and has a cough, it could well be chronic airway inflammation from cigarette smoking. Patients get confused. The patient who comes in and says, I have chronic bronchitis and never smoked cigarettes, but I've gotten cold after cold after cold after cold. That's not chronic bronchitis. That's frequent, recurrent, acute bronchitis. Chronic bronchitis is airway inflammation from regular cigarette smoking. And it is dramatic. Stop smoking, and often, not always, but typically, the cough and phlegm go away within just a few weeks, rather quickly. Effective therapy for chronic bronchitis associated cough. Bronchiectasis we'll have discussed in another lecture in this course, but that's the patient often who has sputum production, and we'll send the sputum for culture and we'll find typical pathogens. We'll get a CAT scan, which is both sensitive and specific for the diagnosis. And I've thrown this in just because I've had this happen a number of times. My patient, I asked, do you have phlegm? Yeah, but it's white, it's not much. Can you show me a sample? And up it comes, and I think the patient must be colorblind because it looks yellow, green, and purulent. I think that's typical of bronchiectasis, chronic airway infection causing cough. And then I promised we'd talk about these other etiologies. Eosinophilic bronchitis was described relatively recently, maybe 30 years ago, as chronic cough without airflow obstruction. So normal spirometry. And yet, if you look at the sputum, there are more than 3% eosinophils on the differential diagnosis. So it's asthma-like eosinophilic airway inflammation, but they don't have airflow obstruction. You, as I, may not have access to sputum white cell differential, but I bet your cytology lab or pathology lab would be willing to look at sputum cytology and give you a qualitative estimate. Few eosinophils, no eosinophils, loaded with eosinophils on a sputum sample that you send for pathology. And these are patients, we talked about the exhaled nitric oxide analyzer. These are patients who would have a very high exhaled nitric oxide value because it's a measure of eosinophilic inflammation. Eosinophilia upregulates nitric oxide synthase and leads to the production of more nitric oxide gas if this test were available to you. And treatment is highly effective with inhaled steroids. So the patient still coughing despite a trial of inhaled steroids probably doesn't have eosinophilic bronchitis. And I thought our patient, the anesthesiologist, probably had post-bronchitic cough. And she may tell us, oh yeah, every time I get a cold, my children get a cold, the cold goes away, and they get all better. I keep coughing, a non-productive, irritative cough that goes on and on and on. You've seen this. You may have had this. It's very common. It's typically a non-productive cough, began with a respiratory infection, it can last a long time. Some people gave it this wonderful name, post-viral tussive syndrome, which is medical talk for a cough that came on after a cold. And then patients say, it seems right here. And if I breathe it, some smoke, or it's dusty, or somebody else's cigarette smoke, sometimes just talking a lot, I can start coughing. Cold air, laughing triggers my cough. And you can just imagine those hypersensitive nerve endings triggered by these irritants causing a non-productive cough. And it often sounds like it's upper airway. It seems to be coming from the throat area. And our treatment for this very common chief complaint, not very effective. We try inhaled steroids. There's one report of inhaled anticholinergics like ipratropium, often not effective. When desperate, we give a short course of oral steroids without much scientific evidence that it helps. And by the time we've made our way through these, with any luck, the cough finally abates on its own. I think these may be buying us time, but maybe just reassurance is enough. Simple cough suppressants, it's post-bronchitic cough, your x-ray's normal, your breathing tests are normal, you're not on an ACE inhibitor. I think it's post-bronchitic cough. Give it a little more, try this cough remedy, and it's going to get better on its own. And then, what about that patient who is coughing not for 8 weeks, but for 8 years? Truly ongoing chronic cough. And I think after the patient presents after years, you can say, well, at least it probably won't kill you because you're still alive 8 years later. What if patients continue to cough despite treatment for these common causes of chronic cough? Here's an example. You may have seen a patient like this. 63-year-old woman seeks your help with a chronic cough. You're my last hope, she says. She's had this cough for 12 years. She's tried everything, the inhalers, the nasal spray, proton pump inhibitors. Nothing seems to help. Physical exam we needed to do, normal. Lung function to rule out obstructive lung disease or restrictive lung disease, normal. We did oxygen saturation at rest and with exercise to exclude occult interstitial disease, normal. Chest x-ray, normal. Chronic, lingering, non-productive cough of years duration. And I think she may have this entity. Have you heard of it? They've been talked about quite a bit in recent years. Cough hypersensitivity syndrome. It's a little bit like post-bronchitic cough on a chronic long-term basis. It's typically women more than men. It's typically peaks in the 50s and 60s when described in case series, but it can be men or women of any age. And people have thought maybe the etiology is some abnormal sensory properties of the nerve endings or afferent transmission, a neuropathic etiology. People have talked about it as a laryngeal sensory neuropathy. And maybe it's hard to prove, but this has led to thinking about its treatment of chronic cough hypersensitivity syndrome with neuroactive agents. There's small series suggesting that gabapentin and amitriptyline may be effective. Trouble is they often have side effects. And again, in small series, if you happen to have this resource of speech pathologists familiar with this entity, specialized speech therapy programs have been effective in controlling functioning of the upper airway, but they're hard to come by. So what evaluation in that patient who's had cough now for seemingly years or months and years? I would do a chest CAT scan. I did read the recent European Respiratory Society cough guidelines. They did not recommend routine chest CT scan, so this is going to be my opinion. But I think you might exclude a little bit of bronchiectasis, that small, slow-growing adenocarcinoma in situ, or some other etiology for this bronchiectasis. It might be abnormal, or just a normal CAT scan is so reassuring. You can tell your patient your CAT scan is normal, your lung function is normal, your oxygen is normal, your chest exam is normal. It's okay. This cough is an irritant, it's frustrating, etc. We'll try things that might quiet it, but it is nothing terrible. And of course, the patient is thinking, oh, I must have cancer, I must have tuberculosis. If there's sputum, let's send it for culture or cytology. I've put bronchoscopy in parentheses. It's tempting to say, well, let's look, there must be something there, but the yield is very, very low. They say like 1 in 100. So not a high yield procedure for evaluating chronic cough. And I would say keep an open mind. Maybe after a year or so, we're going to look into this again, reevaluate, retest, etc. We're just not sure. But to call it, oh, it must be your postnasal drip or reflux or asthma, is probably not the right answer. We need to be humble. Or as was said a number of years ago by people who question these limited diagnoses for chronic cough, is that clinicians are frequently struck by the discrepancy between their own experience in managing chronic cough and these high cure rates suggested by, promised by reported case series. The data was case series. Patients might become frustrated by the absence of substantial progress and their fear fueled by endless investigations, unsuccessful treatment trials, if we assume that it must be asthma, reflux, or postnasal drip. And they went on, large-scale recognition is needed of the substantial number of patients whose chronic cough cannot be diagnosed and controlled with present investigation and treatment options, the treatment protocol. So what do we have available for suppressing chronic cough? probably not as effective as analgesics for chronic pain. We have a benzonatate, those golden gel caps. Have you ever used those? I think some patients report that they were placebo. Others find that they are highly effective. They have a chemical structure somewhat related to topical anesthetics like lidocaine, so that might be their mechanism of action. Worth a trial. Dextromethorphan is the DM of all those over-the-counter cough remedies, a weak centrally acting suppressant. And then opioids are probably most effective. Morphine sulfate is what the European Respiratory Society mentioned as effective cough suppressant. I wouldn't do it, especially in the age of our opioid epidemic. You got to stay away from these medicines on any regular basis and hope that there will be new, more effective anti-tussive therapies. And some are in development and in early trials, including here's one, gefapixant, which targets, we began with those nerve endings, this purinergic receptor 2x3, targeting that and antagonizing that may quiet cough and give us hope for the future for more effective cough suppressive therapy. All right, let's do our pop quiz and then we'll done. This is a 33-year-old mother of two who complains that for years every cold quickly settles in my chest with cough and congestion for 1 to 2 weeks, as often as 3 to 4 times a year. How would you describe her condition? And you've seen the parents of young children, lots of chest colds. Is this chronic bronchitis? Is it recurrent bronchitis? Asthmatic bronchitis? Eosinophilic bronchitis? Well, we haven't done a lot of diagnostic testing, but at least by history, it is recurrent bronchitis. We agreed on how we would describe these episodes. It's not chronic bronchitis, and we'll need to do more testing to see if she has asthma or eosinophilic airway disease, although these are discrete episodes, probably triggered by respiratory infections. I've included some references and enjoyed talking to you about chronic cough.